Good morning, everybody. I'll be explaining the procedures of the form, how to fill the form, which is actually the essence of the RAP survey. And it's actually not so simple. And we have no financial interest involved. This is the form. It has got 7 sections, and I'll be explaining each and every section in detail, what to do and what not to do. How to fill the form was the general guidelines. The manuals, the standard manual developed by ICH, it says it should be filled in pencil. The column should be shaded with pencil, but our experience is the pencil entries, they fade with time and they are not so legible. So we would prefer a black pen. If at all there is an erroneous entry, you can always strike it off with red pen and correct it, fill another entry in red, and always sign in date so that it can be verified. I mean, the data entry can always verify with if it's not legible, with the person who has made the entry. There are 3 types of entries. There is a square box, there's a circle, and there's a line. The boxes are to be filled with a specific number, like cluster code, age, and area code, individual code. The boxes are to be filled in with the number, and the circles are to be shaded. The lines are, you have to enter the text on the line, like name of the patient or the name of the area. You write it is preferable that you enter in capital letters so that the handwriting is legible and the data entry operator can very well understand what is written there. There are 7 sections. Section A is general information. General information, you have to first enter the survey area. Survey area can be a district, province, country, depending on where the survey is being conducted. Like in our country, if we are conducting a survey in 60 districts, we would like to fill the name of the district in the survey area. And we usually assign a code to the survey area as well. So just next to the survey area line, there is a box where you have to enter the survey code. And that survey code should be matched with the list of, with the manual of instructions or the code list provided to every team. The next is the section for cluster code, which is once again to be matched from the list of the sample design and list of the codes provided to every team. Then year and month are to be entered. The name of the person who's to be examined should be entered here, so that in case patient is not available at that particular time, we can go and try to locate it at a later date. The sex has to be entered, the boxes and the circles are to be shaded appropriately. Age has to be entered in numbers. It's a 2-digit number. Suppose the patient whom you are examining is more than 99 years of age. You have to enter the code as 99. For a 102-year-old subject, you have to enter the code as 99. And it has to be more than 50 because the survey is designed for 50 plus population. If you try entering 49, the software will not take. So make sure that there's no approximation involved here. The age is about completed years. So the software, please remember, the software will not take age less than 50. The individual number assigned according to the enumeration. Name has to be entered in legible handwriting. Then there are 2 sections of optional, 1 and 2 here. This is left open to every team. You can fill whatever socioeconomic indicators you want to fill in that. Just don't get too ambitious with it. If you put too many variables, which you will have problem to reanalyzing. Examination status, you have to mark if you are examining the patient during the survey. If the subject is absent despite repeated visits, mark as 2. If there is refusal, some people would not want to go through the entire examination procedures. There will be complete refusal. Even after repeated counseling, after repeated visits, they have to be marked as 3. And if somebody is mentally retarded, suffering from psychiatric illness, or some illness due to which the person is unable to communicate, you have to mark the option 4. For all these subjects who are marked 2, 3 or 4, you go to section E of the form, which gives you the details of subjects not examined. You take the history from the closest possible informant, like a spouse or a parent, or the closest, or a child even if the parent is not available. You have to ask for a history of possible blindness. So if the subject who is not being examined is not able to, we have defined all the terms. If the subject is not able to carry on his social or economic functions, day-to-day activities because of visual disability, that person is believed to be blind. And that blindness could be due to cataract. I mean, you can use the local language for the cataract and ask if the person, for example, in India we take motia, you can always ask the relatives or the informants whether the person is suffering from cataract or whether from any other cause. And they have to be adequately filled for each eye separately. And then you can always ask for history of cataract surgery, and only cataract surgery. Or any other eye surgery does not count here. So the responses for the surgery are also to be entered separately for each eye after taking appropriate history from the informants. Section B is to be very carefully filled. It usually causes maximum confusion. It is the presenting vision for distance. So first and foremost, because it is presenting visual acuity, you take the history of using glasses for distance vision and enter it appropriately. If the patient is using spectacles for distance vision, please ask him or her to get his spectacles and examine the visual acuity with the available spectacles. Suppose the patient has been using spectacles and he doesn't have them at that particular time, like they're broken or something, please mark them as no, because the glasses are not available. This is not presenting visual acuity with the glasses. So only if the patient is going to be using them in that particular examination, please mark yes. And then ask the patient to use those glasses while testing the visual acuity. So you test with optotypes of 6x60 and 6x18 at 6 meters. If the patient is able to read 6, first explain, because it's like we are using E-chart. You can use Landau's E-chart in replacement, and you have to carefully explain the patient which directions. I mean, he has to point out the directions. Then you use 660 chart at 6 meters distance in broad daylight with available correction. And if the patient is not able to see 660, then you go to 660. And if the patient is able to read 660 well, then please show him the 6x18 optotype. We have used 660 first because they are bigger and patient understands them better. I mean, normally we start with the 6 when in clinical. We usually see if patient is not reading 618, then we go to a higher, But in RAB, we use 660 first so that the patient is comfortable with the directions, comfortable with the chart, and then if he is able to read 660 easily, we go to 618. If he reads 618 without the pinhole with the available correction, then we go to the next section, mark it accordingly, and then we go to the next section in vision with pinhole. And I mean, we can actually, if the patient is reading 616 without pinhole, you can just mark the option number 1 in the next section and just go on to next. But if the patient cannot see 618 but can see 660, then give him the pinhole for each individual eye and again examine. If the patient becomes better with 618, you mark the appropriate section in the next, appropriate response in the next section. But if the patient cannot see 660, show him 660 optotype at 3 meters. If he does not respond to 3x60 also, show him the same optotype at 1 meter. If no response even at 1/60, then please examine for perception of light in shaded or dark area. And after examining the perception of light, whether it's PL positive or PL negative, mark the appropriate section. Once again, you give the patient pinhole if patient is not 618, and then you mark the appropriate responses accordingly at 660, 3x60, 1/60, and so on. Each response has to be recorded separately in both the eyes. Each eye has to be examined using occluder. It's not a binocular vision, it's a uniocular vision. Next section is for the lens examination. If the patient has 6x18, it's usually done with a torchlight. You can use portable slit lamp optionally or a distant direct ophthalmoscopy to do this lens examination. If the patient has 618 vision and you see torchlight examination, there is no or minimal lens opacity, which is unlikely to cause a diminution of vision less than 6x18. I mean, that's very important because so many times on torchlight we see there is a opacity, grayish opacity, nuclear cataract, but it is improving with pinhole. It is not causing a diminution of vision less than 618. then we mark the option as normal lens or minimal lens opacity. We mark the option as 1, because if we mark the option as obvious lens opacity, option 2, and the patient has vision 618, it will give a red sign in the software. The software will not take up these entries. There will be inconsistency. So you will be stuck when the data entry operator is entering the data into the software, RAP software. So please make sure that the lens opacity is significant enough to cause a visual acuity diminution less than 618. I mean, it should be at least 680, because the next option is 660. Similarly, examine for aphakia, pseudophakia without PCO, pseudophakia with PCO. Pseudophakia, if you see an obvious PCO, posterior capsular opacity, which is like undilated pupil, you can see a significant opacity once again, which you think, it's a clinical judgment, can cause an opacity less than 618. I mean, can cause a visual acuity less than 618. Mark this option, pseudophakia with PCO, only if you think it is causing significant visual diminution. Because again there will be a contradiction in the software, it will not accept the entry. Look for aphakia, pseudophakia, PCO. Then comes the next section, principal cause of presenting visual acuity less than 6/18. Enter this section only if the presenting cause of, I mean actually it has to be entered for all the sections. For visual acuity less than 6/18, please, if you think there could be another cause beyond cataract or refractive error, please dilate the patient and examine with an ophthalmoscope or a portable slit lamp, whichever you think appropriate. And look for and do a fundus examination, corneal examination, look for signs of glaucoma or any other disease which might be causing a diminution of vision. This is general guideline for refractive error. Option 1. Mark it only if the unaided, presenting visual acuity without pinhole is less than 6/18, but when you give the pinhole, it is improving to 6/18. In this section, if you see, the patient can see 618, cannot see 618, but when you give the pinhole, patient can see 618. Then you mark the cause as refractive error. Cataract, if you have already marked obvious lens opacity and the vision is less than 6/18, even after pinhole. Uncorrected aphakia improving with correction or pinhole to better than 6/60. Surgical complications, if there is evidence that the surgical process, the cataract surgery has led to a complication which is, it's intraoperative complications which have led to diminution of visual acuity beyond 6/18. Central corneal scarring along with one or more signs of trachoma like trichiasis, entropion, pannus or Hubbard's pit, only then mark trachoma. Other corneal scar like any history of infectious keratitis or vitamin A deficiency, and you will see a corneal scar, then please mark as this option. Any globe abnormality like microphthalmos, anophthalmos, enucleated eye, even phthisis, glaucoma, mark if the eye is stony hard on palpation, CDR is more than 0.8, and there is a afferent pupillary defect with corneal edema. You have to be absolutely sure the diminution of, there's no other cause, and diminution of vision is due to glaucoma. Either patient is an absolute eye or known history of glaucoma, and you see advanced glaucomatous cupping or corneal edema. Diabetic retinopathy, please mark DR as a cause of blindness only if it is PDR or diabetic macular edema. Just mild or moderate diabetic retinopathy, please look for other causes of blindness. AMD, a mark if presence of pigmentary changes, drusen, CNVM with or without fluid, or subretinal hemorrhage or macular hole. All other posterior segment disorders are to be classified as option 13. Yeah. And if the patient has 6/18 visual acuity, please mark as option 14, because patient is actually not blind. This is a general guide to which principal order has to be considered. General guideline is the one responsible or contributing to visual loss in the eye, and which is most amenable to prevention or treatment. So the manual gives a general guideline that if there is cataract and there is refractive error, please consider refractive error first. And if there is a cataract and there is glaucoma, but not so significant, and there is more of cataract, please mark as cataract. So there can be 3 or 4 coexisting disorders, but which is most amenable to treatment and which is the principal cause of the visual diminution in that particular patient, please mark as that one. And then there are 2 things. One is principal disorder in the eye and one is principal disorder for the person. So principal disorder in each eye has to be marked separately, like for right eye, left eye, and when you decide the principal cause in person, always consider the better eye. For example, one eye is PL negative and one eye is 6/18. Then please mark option 14. Because the person is actually not blind. The better eye has better than 6/18. So please mark the option as 14, not examine, can see 6/18. So always consider the better eye when marking principal cause in person. Next section is section F, which explains the barrier to cataract surgery. Why cataract surgery was not done in that person required cataract surgery. He was blind because of obvious lens opacity, but the surgery has not been done. So the barriers, there are 13 barriers listed in the form. You can take the history and match the patient's response closest to one of these. Mark at least one and maximum 2 responses. If the patient has been operated for cataract, please take details about the cataract surgery and mark it in the section G. First, take the exact age of the cataract surgery for both the eyes. Take the completed years, not the rounded off age. Then setting of the operation. It could be a government hospital, a voluntary or charitable hospital, private hospital, or an ICAM setting. For ICAM, please make sure that the patient does not, you have to take it slightly elaborated. You have to ask the patient whether the patient was screened in ICAM or operated in ICAM. They are 2 different things. Generally, the patient will respond, camp mein karayi thi. We got it done in a camp. But that may mean that the patient was screened in the camp but operated in a government or voluntary or charitable hospital. So that in that case, you mark the place where the surgery has been done. These days, it's very rare to have surgery being done in a camp setting. That makeshift operation theatre approach is now obsolete. So very rarely you will find patients who would have got operated in camp OT settings. So in that case, you have to take appropriate history, whether a patient was examined in camp, screened in camp, or operated in the camp setting. Then even couching. Traditional settings usually refer to traditional healers or couching, which is once again very rare. So even that history has to be elicited properly, whether they were actually operated by a traditional healer in the home under aseptic conditions or, that kind, or couching was done. This option is basically for that. Then type of surgery, whether IOL was implanted or not. IOL, AC IOL, dislocated IOL, PC IOL, all should be marked as option 2. IOL implant was there, even if it's dislocated. Only non-IOL aphakic surgeries are to be marked as option 1. Then cost of the surgery, whether it was totally free, some patients pay for the lens only, that is considered as partially free. The cost of traveling, accommodation, food and all is not to be concerned. Patient will say, we bought the medicine, so it was not actually free. But that is considered as free surgery. Cost of medicines that patient bought for the follow-up, the accommodation, traveling, all these don't count here. Then cause of visual acuity less than 6/18 after cataract surgery. You have to mark this section very carefully because it should match with the earlier responses that you have said. Here also, there is a general guideline. If visual acuity is less than 6/18 after cataract surgery, you have to assess the cause. Ocular morbidity, comorbidity selection 1, only if the patient had a comorbid condition like glaucoma, ARMG, diabetic retinopathy, which was responsible for the surgery was uncomplicated, but these were the reasons why patient could not regain his vision better than 6/18. Then operative complications, if the poor outcome is due to operative complications like lens drop or wrench causing vitreous in the AC, lot of reaction and all that. Refractive error, if the vision after cataract surgery can be improved with pinhole. Like it's, patient is pseudo-phakic, unaided vision is less than 6/18, but with pinhole it is 6/18, and then you mark this option as refractive error. Even uncorrected aphakics should also be marked as refractive error for this particular question, not in all others. For this particular question, why the vision was less than 18 after cataract surgery, all the uncorrected aphakics should be given option 3. Long-term complications like PCO or pseudophakic RD, phakic RD, I mean late complications of cataract surgery, uncomplicated cataract surgery, but late complications have occurred, then you mark the option 4. Even PBK, ABK, which you would have marked as surgical complications in earlier section, would come as long-term complications in this particular section. Not applicable, can see 618, patient is pseudo-fake, can see 618 without pinhole. Please remember that. If the patient is improving with 6/18 after cataract surgery, option 3 has to be marked. If the patient is unaided 6/18, I mean without the pinhole, then you have to mark as option 5. Finally, ask the questions whether they are satisfied with the results of the cataract surgery. You have multiple options for that. Very satisfied, partially satisfied. It could be any level. Mark accordingly as per the patient gives history. Thank you.
Thank you, Aparna.